Hello, everyone. Welcome to our November webinar for the UCSF Child and Adolescent Psychiatry Portal. Today, our topic is SSRI. Looks like we have a quorum. So we're going to get started with introduction. My name is Ho Hui Eileen Wayne. I'm one of the child and adolescent psychiatrists staffing the CAP consult line. I also help organize CAP CME and educational activities, along with my wonderful colleague, Dr. Joanne John, and our analyst, Jessica Snyder. Before we begin, I have a few housekeeping notes. Today's session will be recorded and it will be posted on our CAP website for viewing. So if you have any questions for the presenter during the talk, please use the Q&A feature. We will also try to save a few minutes after the lecture for live Q&A if possible. For the interest of time, I'm going to go ahead and introduce our speaker today. It is a pleasure to have our expert, Dr. Steinbuchel. Dr. Steinbuchel is a clinical professor in the Division of Child and Adolescent Psychiatry at UCSF Department of Child Psychiatry and Behavioral Sciences. She has provided clinical care at UCSF Benioff Children's Hospital, Oakland, in the setting of general child and adolescent psychiatry in outpatient and school-based clinics with medically underserved populations and consultation liaison psychiatry, as well as in outpatient integrated care models in consultation to pediatricians. Dr. Steinbuchel completed her bachelor's in English and German at the College of William and Mary, her medical degree and an internship in pediatrics at the Medical College of Georgia, and general psychiatry training at California Pacific Medical Center, and child and adolescent psychiatry training at Massachusetts General Hospital. Dr. Steinbuchel is our CAP director. With this, we'll hand it over to Dr. Steinbuchel.
Thanks so much, Eileen, and really happy to be with everybody today in the context of talking about SSRIs in clinical practice in pediatrics. In terms of disclosures, I do serve as an advisor for Little Otter Health, which is a virtual platform aimed at delivering mental health care for children ages 0 to 12. And I also want to note that CAP is supported by federal and state grant funding, including HRSA and DHCS Prop 56 Behavioral Health Integration Funding. So today we're going to be talking about 3 commonly used SSRIs, and would love for you to be able to become more comfortable with usual initial and target dosing for these, and also more comfortable with explaining about SSRI risks and common side effects, including the risk of activation, and also be able to develop your own language pearls for patients and families when you're discussing the anticipated risks, benefits, and side effects of SSRIs. So this is always a hard topic to try and do within just an hour because we use SSRIs for a lot of reasons, but wanted to kind of walk through some initial things that you want to think about when you're considering SSRIs with your patients. We've had a lot of really great talks on depression, anxiety, suicidality, and I think it's helpful to have those in advance of talking about the use of SSRIs. All of this really starts with having an accurate diagnostic assessment and also being able to assess for common comorbid conditions, because often one of these things just doesn't come alone. It usually is in conjunction with other disorders. Just doing consults with many of you, it does seem like a lot of people are using screeners in advance, and so I don't know how integrated that is into your practice, but common screeners like the PHQ-9, as well as the GAD-7 and the SCARED for being able to quantify anxiety symptoms can be really helpful. So just a little bit more about common screeners that we use. I think many are familiar with the GAD-7, which is validated down to age 12 and up. The SCARED is a longer form that does take a little bit longer, and it's validated for ages 8 to 18. That said, some of the questions do sound like they might be relevant for a younger child. And so if it's a teenager, I just name that up front to try and help them know that some of the questions might sound like, it should be for a younger, say 10-year-old. but it does help to really classify some of the main areas for anxiety, like generalized anxiety, social anxiety, performance anxiety, and obsessive thinking. And then the commonly used ones that we use for depression are the PHQ-2 and PHQ-9, of course, which are validated down to age 12. Another one that I find really helpful is the mood and feelings questionnaire. And this one is validated down to age 6. So this can be helpful at looking at some of the questions around self-esteem that often go along with depression. And again, can be used for younger kids. And then the ARCADS is a questionnaire for ages 8 to 18 that can be used to assess both mood and anxiety symptoms. And to the right, we just have a kind of brief classification, thinking about, really very few symptoms that are not clinically significant, and then minimum, moderate to severe, and severe, to help you think about what kinds of interventions might be indicated depending on the score. Again, these screening tools and rating scales are used as a measure, but it's not meant to completely dictate what you do. It has to be in the context of clinical judgment and what is happening with the patient in front of you, which we know varies. Another consideration is to really check for comorbid conditions that include medical disorders and then substances. And I think sometimes we can, think in our minds, oh, this is definitely mental health, but it is important, if you have any indication that there may be something else going on, to check for, the common comorbidities, like, for example, checking thyroid or checking a CBC, especially in a menstruating female. And then checking for substances, with common things being really common, including steroid use and caffeine, and then other stimulants. You also want to screen for any red flags that include not only substance use, but also, is there a family history of bipolar, or are there any bipolar symptoms that may be kind of more mild? Is there any self-injury or risk for suicide, or concerns for psychosis and or an eating disorder? And just a little bit about substance use. So a lot of youth who have a substance use disorder also have depression. Which came first and which came second is sometimes a matter of debate, but just knowing that these often do come together is important to think about. And, and that these can be risk factors for some of the really unfortunate consequences of depression, such as increased suicide risk. And the bottom line is that often treating them both together in kind of a developmental context is what can be most effective. Another important factor to consider is screening for the risk of suicide. And we had a really wonderful presentation by Dr. Wang here, and also by Shelley Nakaishi on suicide risk assessment. And we'll be having another coming up shortly. So I'll refer you to those recorded webinars online, but just briefly, that you want to consider doing at least a brief risk assessment. And as you can see from this, this is not intended to take a long time, but it is an important component of your overall evaluation. In the PHQ-9, it's a really wonderful, well-validated screening tool. And the questions around suicide are really not super specific, in that it asks, do you have any thoughts of being better off dead or of hurting yourself in some way, which can be very different things. So these follow-up questions for the teen PHQ-9 can be really helpful in terms of asking a little bit more about, has there been a time in the past month when you've had serious thoughts about ending your life? And then, have you ever made a suicide attempt? The ASQ that is recommended by the AP and the AP Blueprint is a similar 4-question screener that can really help to assess suicide risk. And if any of that is positive, then you want to be able to do a deeper dive assessment that can take 10 minutes or so. Another really important aspect of treatment is just being able to identify target goals. And ideally, this would happen when you're assessing for depression or anxiety. What is one thing, if life could be different in 3 months, that you would like to see be better? And sometimes youth have a hard time, identifying these, but you can really base it on some of their responses to the PHQ-9, for example. I wish that I had more energy. I wish that I felt less sad or less lonely. And that can be a real kind of more qualitative way of assessing, has there been improvement in addition to follow-up PHQ-9 scores? So another part of this that I think we often underestimate the importance of is psychoeducation. Just hearing, that the way that I've been feeling doesn't mean that I'm crazy, doesn't mean that there's something really profoundly wrong with me. It just means that I have a diagnosable condition that is worthy of treatment and that there are treatment options available. It's important to look at just what is the kind of monitoring of target symptoms that you want to identify and follow up on, and perhaps schedule more frequent, and these can be brief, but more frequent follow-up visits during the first 1 to 3 months. This really helps to build rapport. It really helps youth feel like you are addressing their problems. Remember, the placebo effect of medication is usually about 30% across a lot of different studies, and some of that might be because of just engagement with a caring other. Also thinking about other resources that are not clinical, like engagement in really, positive activities, peer support groups, and then what are some self-management goals that you can also enlist the family in, so that it's not just, talking about eating more healthfully, but perhaps talking about, planning and doing a family meal together. These are some evidence-based treatments here for depression. So cognitive behavioral therapy, which really explores the relationship between your thoughts, your mood and feelings, your behavior. And then also, it says here physical reactions, but this can be also your physical environment. And we don't really have control over our mood or feelings. We can choose what we do with that. So we do have some control of our behavior, and we can try to affect how we think about things. And then we may modify our physical, both reactions and sensations. For example, if I'm hungry, I might be more likely to be irritable or to feel stressed. So I can change that, or I can change how much sleep I'm getting. And then that will hopefully impact my mood. Interpersonal therapy for adolescents is a way of thinking about kind of current relationships, and with some problem solving around some of those relationships that can help create a more positive mood. In terms of CBT for anxiety, it works in a similar way and really explores a lot about automatic thoughts that can happen in response to stress that may be a more extreme, what are called thought distortion, that that person really doesn't like me because they didn't say hi to me. Well, let's look at the evidence for that. Is that really true? Or is maybe something going on with them that you could be curious about? And maybe that's why they didn't even see you, because they're feeling stressed themselves. Here is a resource around self-guided CBT for anxiety. These are newer interventions, the Schleider Lab interventions, but these are accessible for teens. Coping Cat is a CBT modality that's been around for a long, long time and can be really helpful. And in this case, the Coping Cat for parents can help parents to learn the ways that they inadvertently reinforce anxiety. For example, if a child says, I think there are monsters in the closet, and then they say, oh, well, okay, let me go check. And then, checks, no, they're not there. That can be kind of reinforcing because it gives the idea that, yes, there are monsters in the closet. They're not there now, but I'm going to respond to your request to do this. Instead, they can find other ways to respond. This talks a little bit more about additional interventions in addition to CBT and interpersonal therapy that include family therapy and also dialectical behavioral therapy, which was initially not designed for people who experience chronic emotional dysregulation and suicidality in response to problems, and can be a really effective skills-based and also family context intervention. So when you prescribe in primary care, this is not necessarily kind of a first line go-to automatic thing that you want to do, but really more so when the condition is moderate, when it really seems to be significantly impairing and there's a risk to current functioning if they've had a failed or a partial response to therapy only, plus these other active supports. Also importantly, that the parent and the patient agree and that you've been able to deliver education about risks and benefits. Also knowing the patient is really important. So this means, someone that you just met for the first time who's coming in with a lot of anxiety, but you don't know much about their psychosocial context, or you don't know if they're going to be likely to follow up. Sometimes taking an SSRI only intermittently can actually cause more risk than not doing anything. So it's always okay to wait and not necessarily prescribe on the first visit unless you feel confident and comfortable that it's appropriate. And then ideally that you'd have the ability to consult and collaborate as needed. So medication can also serve as a bridge. We really, talk about wanting to engage in therapy first for anxiety and depression, and acknowledge that therapy services can be really challenging to access because of the sheer numbers in terms of demand for services and then the limited availability of providers. And so at times medication can help to get through a really difficult time. And also as a bridge for you as a PCP to be able to, to start something and then ideally refer on to a child psychiatrist if you feel like the current situation is beyond your comfort zone. And in terms of general guidelines, so SSRI efficacy is similar across different medication types. They really work in a similar way. And the selection is just based on past response and also side effect profile and coexisting medical conditions. That said, there is more evidence for Prozac in treating depression than there is for some of the other SSRIs, but there are other factors to consider. There's usually a 3 to 6 week time between getting to an appropriate therapeutic dose and then getting to symptom improvement. However, you can start to see some benefit as early as the first couple of weeks. If there's not significant improvement at 8 weeks at a reasonable dose, then you can consider switching to another antidepressant or augmenting with another agent. And then overall, in terms of the evidence for these medications, there is kind of bigger picture, more evidence in favor of treating anxiety disorders, especially in younger patients, than there is for use of SSRIs in depression, where the data are a little bit more mixed. So this is a really, the slide has a lot of information and a little bit of visuals, but basically it's a summary of the major studies that have been done in studying pediatric depression. So for the TAD study, this one showed that, and the stands for Treatment of Adolescent Depression Study, the study showed that basically cognitive behavioral therapy plus Prozac was better than Prozac alone, which was better than cognitive behavioral therapy alone, and all of these were better than placebo. In the TORDIA study, which stands for Treatment of Resistant Depression in Adolescents, that the factors associated with a positive response included early response to medication, augmenting with CBT, and then factors that are associated with a poor response were, of course, comorbid substance use, worsening symptoms, and in particular, anhedonia, not really being able to experience joy in most things, and then family conflict that's ongoing. In the ADAPT study, which was done in England, and the reason that the study was done was in part looking at available resources, again, back to the availability of therapy, even though therapy would be a preferred treatment modality, as a first step, that being able to prescribe a medication is of course easier to do sometimes than accessing a therapist. And so this study found that SSRIs plus CBT were equivalent to SSRIs alone. And then in terms of this walk-up analysis, this is an editorial that John Walkup did, who has really researched a lot of pediatric anxiety disorders, in particular, talking about kind of the pharma-informed literature that was really more of what was looked at in the late 90s and early 2000s before there were more regulations, and that it's really important to look at how a study was done, who funded it, and what is kind of the number needed to treat that gets FDA approval. In anxiety disorders, basically, there are multiple studies that have been done on this, and that the overall benefit of SSRIs in treating pediatric anxiety disorders seems to be about 30% over placebo. So when you're talking about this with families, it's important to talk about kind of the dilemma. Many families are, in general, not wild about the idea of having their child take a medication. Some families may, really want just a very biological, more what feels like a quick fix, rather than sometimes doing the hard work of therapy or other environmental adjustments. And there's just really a whole continuum of what people are hoping for from a medication. But I think it's important to just talk about, what are the risks of using an SSRI? What are the anticipated benefits? And then what are the risks and benefits of not using a medication to treat this? And so in terms of risks, there are unknown effects on brain development. That said, Prozac has been around for about 40 years at this, for 30 years, at this point. So it has been around for a long time. And the other SSRIs have mostly come out in the 90s. So we do know, a fair amount about them. And then, of course, the idea of stigma. And then thinking about the benefits, and this is really important, is that this is supposed to help your child feel more like themselves, that they can feel more capable of doing the things that they used to enjoy or be good at. And with that, then they can more fully engage in all of the important developmental experiences that they are engaged in, particular school, with peers, different activities, with family, and without, significantly or without really impacting their kind of overall personality in any significant way. And then, of course, the risks of not treating is that, if you are very symptomatic, and it's impairing your functioning, then that poses a risk for not just right now, but ongoing development. And of course, the benefits of not using would mean no exposure to medications. Ideally, you want to get consent together with a medication handout covering the risks and benefits. This is something that's required in specialty mental health, is for a parent to give consent to take the medication. That said, it's not required in pediatrics, but it is best practice to at least, document verbal consent, and that you've been able to review the risks and benefits. And then thinking about, the form for that. So there is a specific form if you're providing care through specialty mental health. And then if a child is in foster care, there needs to be court approval for doing the medication through a JV 220. So when I move on a little bit to kind of, when you actually get to prescribing, and have us think about what does it mean, to be starting a medication, and how do we know what's working? How do we know how long to use it for? So having an initial response means no symptoms or significant reduction for at least 2 weeks. Having a remission is having a longer period with no or very few symptoms, so 2 weeks to 2 months. And then recovery means much less symptoms or no symptoms for more than 2 months. However, then you also want to think about preventing relapses or recurrences. And there are usually three treatment phases. One is the acute phase, and then one is continuation, and then maintenance. And then there may be, of course, discontinuation. So basically, like we said before, SSRIs do work in a similar way. They block the presynaptic serotonin uptake. There's some common side effects that we know are likely to happen, especially at the very beginning of treatment. GI upset can be more likely, as well as potentially headaches. And the way to prevent that is by starting at the very smallest possible dose and then going to the lowest effective dose. And also ideally taking it together with some food can really help to prevent that initial GI upset. Sometimes for teenagers, especially, who may or may not eat breakfast, may or may not eat any lunch, this can be a little bit more challenging to do. But I usually ask families, if dinner, which is usually the most reliable meal, if that's the time when the teen could take it, that might be a good time to schedule in, so that you ensure that somebody's eating. And because otherwise, if they take it on an empty stomach, then they might feel nauseated and then not hungry, and then it perpetuates itself and they continue to feel more nauseated. Other things that are here, like restlessness, nervousness, are things that we'll talk about a little bit when we talk about activation. So we'll come back to that. Sexual dysfunction is very real. It can happen between 30 to 50% of people who take SSRIs. And so that is an important thing to ask about. It may be a reason for, non-adherence, or an area of concern that a youth may be really reluctant to bring up on their own. There's very little risk of cardiotoxicity and overdose. And so that's a helpful consideration, in contrast to past tricyclics that we used to use to treat depression, which had much more risk of overdose. And in terms of which one to choose first, for treating depression, fluoxetine does have the most evidence behind it, and then Lexapro, and then Zoloft. So here's a chart with some helpful information about, what form does it come in. Thankfully, most of these come in both tablet and liquid form. I will say the liquid form does not taste good. This is not the, bubblegum or cherry flavored Augmentin or amoxicillin that kids may be used to. So just to note that if they say, I don't know about swallowing pills, I prefer a liquid. The amount is usually very small, but it can be a little bit bitter tasting. So for some kids that works and others it doesn't. But you can note that, there are tablets that can be crushed and sometimes compounded by certain pharmacies. And then here's kind of a usual ideal starting dose based on age. And then what's a typical effective dose. And what's here is a typical effective dose for depression. It may be that it's higher for anxiety. Sometimes higher doses of SSRIs are needed to treat anxiety than what's required to treat depression. And then here we've got, are there randomized controlled trials in support of these medications and for what conditions? And then is there FDA approval? Here are just a few kind of pearls about the most commonly used SSRIs. Prozac, if anything, can be a little bit activating and so make people feel more energetic. That said, it can also make people feel more tired. So, don't be surprised if they complain of either. But I like to think about Prozac, especially for youth where they may be kind of more, sluggish, slowed down, underactivated, not very motivated to engage in their usual activities. And this is also really good for patients where you're concerned about adherence, because it has such a long half-life that, missing it one day is not going to cause a lot of withdrawal symptoms or problems. So it's something important to consider. This is also, because of that, this is the only one that you can just stop without tapering it, and will just self-taper. Zoloft is really nice for, in particular, anxiety, and has some indications for pediatric anxiety and OCD. If anything, it might be slightly sedating, so some people prefer taking it at night. And also of note, it can have a mild dopamine blocking effect. I did get a call once from someone who had accidentally taken 2 of their Zoloft, and they actually had a dystonic reaction like you would see with, high doses of an antipsychotic. Luvox is one that has some approval for OCD. This one, it's important to note that it has a half-life of about 15 hours. And so often people will dose this twice a day, which can be kind of cumbersome for people to remember. And then Lexapro, most of the ones outside of Prozac have a half-life of about 1 day. And so with that, you may start to feel some withdrawal symptoms if you don't take it for 2 to 3 or more days. This one can be activating or sedating and is thought to have less sexual side effects. And then Celexa is similar, and this one has kind of the least drug-drug interactions. Paxil is one that can honestly say I've never started in a youth because it does have a lot of side effects and has been most associated with the risk of suicidal thinking of all of these. So again, here's some common SSRI side effects. The stomach upset and GI impact can be significant. Then also headaches, potentially changes in sleep, changes in appetite that might be related to the GI effects, a sexual dysfunction. And then the flu-like symptoms usually happen more upon discontinuation of the medication, especially if you stop it abruptly from a higher dose. In terms of more rare side effects, we'll talk about the suicidal thinking and the FDA warning in just a moment, as well as about activation, agitation, altered platelet functioning. This can happen because SSRIs can inhibit platelet aggregation. So someone may be a little bit more, risk of bruising easily. So if you're seeing somebody who has, new bruises all over their legs or is starting to talk about, getting bruising without really any significant activity that would explain it, then you want to check for this. And there is not, they're not really great recommendations around when this happens, what you should do. But in order to stop it, you do need to stop the medication. And then you can potentially try a different SSRI, but there's no guarantee that it wouldn't happen again. And then more rarely, it can cause hyponatremia or hypernatremia, serotonin syndrome. And then there has been kind of there's a marginal impact on the seizure threshold in vulnerable individuals, especially. So thinking about talking with parents about this, a lot of parents will ask, oh, is this going to change my child's personality, or are they going to be a zombie from this? And, the reality is that this is not intended to change anybody's personality. Sometimes when the dose gets to be too high, you can have what's called a flattening of affect, meaning, someone will say, well, I don't get anxious anymore, but I also don't, feel joy. I don't feel happy. I felt like I should cry and I wanted to cry, but I just couldn't. And if that is happening, that can be a signal that the dose is too high. And so it's important to take a look at, when this change happened, how does that correlate with any dosing adjustments, and then consider going down on the dose. Can also consider changing antidepressants, but as a first step would go down on the dose. And then in terms of the kind of personality impact piece, this is also a common thing that youth themselves will talk about. And what I try to do is just ask them to think about a time when they felt like things were going well for them, and this may be going back to, okay, well, in 3rd grade, I had a lot of friends and I really liked school and I loved, playing baseball. And so then when you're talking about, the potential help that medication could help facilitate, it's supposed to help you feel like you did in 3rd grade. But it's not supposed to change who you are, how you think, or how you act. And also that there's no addiction potential with a medication like this. And the goal is overall to help you feel better and be able to participate in all of your life. And with that, I think for kids to know that it's not going to be something that they have to take for any length of time if it's not working for them. Parents also often have read about the FDA warning around increased risk of suicide with these medications. And the way that I like to talk about this with families is, to say there's a long list of possible side effects. If you read the package insert, you'll see that we're not going to cover all of those, but the most common ones are, the potential for some stomach upset, and so talk about the ways to help prevent that. And we're going to start really slowly and start with the very lowest dose and then go to the lowest effective dose. And the most important person in this is you. And this is meant to be a partnership. I want you to be front and center in this. And if you're noticing any new side effects, then I really want you to call before our next appointment and let me know. And I'd much rather hear from you than not hear from you. One side effect, a potential that we need to talk about is that, as you may have heard, there was a warning put out by the FDA in 2004 that looked at 24 randomized controlled trials, some of which were published by drug companies and some of which were unpublished by drug companies because they weren't favorable. And that review showed that there were about 2.2% of kids who took placebo medication compared with 3.8% of kids who took SSRIs, and found that in those, there was an increased risk of suicidal thinking in that percentage. So it's not a big percentage, but it is, there, and it's more than placebo. That said, this is not something that happens all of a sudden after things have been going well for some time. It really is, usually along with maybe feeling more irritable, feeling worse, feeling more agitated. So I'd rather hear from you, than not. And because that means that things are not going in the right direction. And so usually people feel a little bit better having broken that down. Also of note that there weren't actually any increased completed suicides in those studies. It was just an increased risk of suicidal thinking. So related to this, the highest risk for developing this seems to be in the first 9 or so days of treatment. And this seems to be somewhat associated with the risk of what's called activation, which is kind of a composite of different symptoms that include agitation, anxiety, irritability, physical restlessness. And so if you're seeing anything new like that, it's important to call. In terms of overall risk, so this is highest in those first 9 to 10 days and seems to be related to significant increases in blood levels of the medication. That's again why we start at the lowest dose and then go to the lowest effective dose. That risk then decreases. And another kind of timestamp to keep in mind is that, it's highest in the first 9 days, then in the first month, and then in the first 3 months. And then after that, unless there's a significant dosing change, then, the risk of suicide related to the medication is thought to be, unlikely that it's actually linked to the SSRI, and more so because of other factors. This is just showing that, the suicide rate amongst youth was decreasing, and then the FDA warning came out, and of course at that time pediatricians felt less comfortable prescribing SSRIs and did so less. And then we know that, since then the suicide rate has continued to go up. That means it's a correlation, but it's not a causation. But the short of it is that depression is worth treating, and SSRIs, can be really helpful as a component of overall treatment. And the actual risk from SSRIs is important, but low. So activation is something that is more common than the risk of developing suicidal thinking. And studies will show that this is anywhere between, less than 10% to as much as 50% of people who take it. It does seem to be inversely related to the patient's age. So the younger the child, the more at risk they may be for this. And it usually happens at the very beginning of treatment, or if there's a dose increase, and something really that's important is a rapid rise in serum levels. So overall, you want to assess, are they taking it consistently? Because if you're taking it inconsistently, then you can have those rapid rise and falls of the the blood levels. You can also think about, if this does happen, first initially decreasing the dose as a mitigating step if it's not really significant, or you can think about stopping it and then think about switching to a different SSRI. That said, if you've experienced this with one SSRI, then you are more likely to develop this also with another SSRI. If there is overall benefit and you have this akathisia or physical restlessness as kind of the main side effect, then you can treat that with a beta blocker if overall there's significant improvement with the med. It's really important to distinguish bipolar switching from behavioral activation, because sometimes the two get mistaken for one another. So activation is something that happens in the initial days to weeks after starting or after a dose increase. And there's not significant change in mood. It's more these things that are more like psychomotor, nervousness, akathisia, irritability. And this does not mean that someone is going to go on to develop bipolar disorder. Bipolar switching, on the other hand, or SSRI-induced mania, can occur later in treatment and may not abate with discontinuation. And the mood changes from depressed or anxious to manic or hypomanic. This is less common, and it's something, again, that happens later in treatment. And after reevaluation, it may mean that the person needs a more mood stabilizing medication first and not an SSRI. Serotonin syndrome is something that is uncommon, and this is something that can develop usually within 24 hours of starting or really increasing a dose. You can have hyperreactivity in terms of reflexes and tremor, and the reasons are a serotonergic agent, and treatment can include benzos and cyproheptadine. It usually resolves fairly quickly. And MS, on the other hand, is something that evolves usually over days to weeks. And the important distinction is that you can have slowed reflexes and severe muscular rigidity. And this is from dopamine antagonism. So this is usually when people are also taking antipsychotic medications. In terms of monitoring and follow-up, so in the first month, with the FDA warning around the risk of suicide, the initial suggestions were to monitor weekly and for the first month, and then to space out to every other week during the second month, and then potentially move on to monthly monitoring for the first 6 to 12 months. And then once someone is stable on a particular medication, then you can space it out a little bit more, up to every 3 months. In reality, sometimes weekly monitoring can be really challenging. So this could include a telephone call or an invitation to call, and then to see them back within the first 10 days. And the indication is to increase the dose from that very small initial dose to what would be considered a typical therapeutic dose, as long as they're not experiencing side effects. And you can do that every 2 to 4 weeks. In terms of cross tapering, if you're finding that something is not working, or if there are side effects, then you can kind of do this one of two ways. One is to just substitute a new medication at the same dose, a day later. So stop one medication here and then start a new one here. And the relative equivalent would be 75 milligrams of sertraline for 10 milligrams of Lexapro. Generally, the few times that I've done this, I have found it to not go as well as when I do a more gradual taper. So slowly coming down off of one while increasing the other. Sometimes you can decrease the number of days interval where you make a change, but here this is a weekly. So thinking about switching from Lexapro 10 to sertraline 100 milligrams, this would be kind of a slower cross taper. And you can see here going down by a little bit on the Lexapro and starting with the sertraline at 25 and so on. With Prozac, you want to think about that long half-life again. And so you can think about stopping it for about a week, knowing that you're going to get to half that equivalent amount. So if they were taking Prozac 20, then in about a week, it's going to be Prozac 10. and then you can start a new medication, but not at the equivalent of that Prozac 20. You would want it to be lower. In terms of SSRI discontinuation, so again, thinking about adherence and your follow-up visits being a good time to check in about that, and just really practical considerations like, is the timing right for you? Are you trying to take it at a time when you're going to remember? Or, do you never remember right before bed because you end up falling asleep while you're doing something? Or if people stop it abruptly because they don't want to continue to take it. So you can have flu-like symptoms, and then you might feel more nauseated. Sensory disturbances, this can include what people call zaps a lot of times, where it can feel a little bit like a shock-like sensation, maybe in their arms. And this usually happens for maybe 2 to 3 or 4 days, stopping an SSRI. Thinking about treatment journey overall. So, in the acute phase, you're looking to get a response and then ideally remission. And you want to see that period last for at least 6 to 12 weeks before making a change. And this might involve more frequent visits, adjusting the medication based on follow-up PHQ-9 scores or G87 scores, and then thinking about when and in what ways to continue. And the goal is really to prevent relapses. If you have about 4 to 12 months of sustained improvement, and this depends again on, the child or youth themselves, and also where they are maybe in the academic year. For example, stopping, during finals would not be a good idea, whereas waiting until summer vacation, if there's not a lot of stressful things planned, then that might be a better time to try stopping it. In depression in particular, continuing for 9 to 12 months is associated with higher and more sustained remission rates. So that's something important to keep in mind. And then in terms of maintenance, you want to think about a lot of different factors. It may be that this was the first presenting episode of anxiety for you at age 16, but looking back, it looks like they've had kind of lifelong anxiety, and there's anxiety that runs in the family. So you may consider doing it for longer and not just doing it for 6 to 12 months. And then thinking about stopping it, again, you want to look at how long the remission has been, and then what other supports are in place, and thinking about a good time to do this. Maybe not the first semester of freshman year, for example. So in terms of when to call, or to think about calling 911 or going to the emergency room, these would be symptoms of potentially either neuroleptic malignant syndrome or serotonin syndrome. Of course, seizures, any active suicidality, and then these would be things where they can call you as needed. And so I try to kind of explain that to people, when you're talking about creating follow-up appointments. And then I'm going to pause here for questions, and also pull up this slide for claiming CME. And then I think Jessica has a slide to share that also includes an invitation to our next webinar in December.
Thank you for the presentation. And we're going to use some information regarding claiming your CME credits and also our upcoming webinars. So on the left, it's the QR code for you to be able to access your CME credits. And on the right side, there are 2 different webinars in December that we want to share with you. For all the participants, please use the QR code on the left. And we'll also copy and paste it in chat so you can access it in different ways to collect your CME credits for today. For the webinars next month, we actually have 2 separate webinars. One is our regular monthly webinar on December 8th on Thursday, and the other one is our special webinar on December 2nd on a Friday. Sorry, there was an error in the flyer that we sent out earlier, and I just wanted to clarify and remind everyone again that there are two webinars. They are on different days, and one is on the 2nd, the other one is on the 8th. And then you will be able to access the registration for our December 2nd webinar, which is a special webinar via the link that's shown on the slide. So I saw that there are many questions that came in. Also, I think there was one PCP that raised your hand during the lecture. We'll have, actually, because this is a webinar, we'll only be able to see the Q&A, and I'll hand these questions over to Dr. Steinbuchel. So Dr. Frank asks about psychological maltreatment and management for that. And is there a more systematic way to kind of evaluate for these anxiety, psychological maltreatment, and how they contributed to patients' anxiety and depression?
Yeah, I really appreciate this question from Dr. Frank. Thank you. I think, I talked about kind of rating scales and screeners and didn't talk about, the overall, like, what are you doing in your HEADS assessment? What are you doing in your SHADES assessment? How are you, applying what you know about the psychosocial context or ACE screening? And absolutely, that should be a core component of your assessment, whether this is a checkup or, if the chief complaint is around depression or anxiety. So absolutely asking about kind of social factors and any kind of precipitating events. And we didn't really talk about that so much because it's been covered in, some of the other webinars, but I really appreciate the question, and absolutely. Yeah. And in terms of sharing slides, yes, we can share those and figure out a way. We'll explore either posting them to the website or sending them out to the participants here. And then if a verbal consent to start an SSRI was obtained and documented in the chart, but the consent form was not signed, should the consent form be added as soon as possible? This really depends on your context. So the form that I was describing, that is just a requirement for specialty mental health providers. So, in psychiatry, who are seeing, children insured with Medi-Cal, that form is a requirement. It's not a requirement for primary care providers. That said, it would be best practices if you can, document that and have it in the chart. But I think if you just include, your own written description of the verbal consent process, including any highlights. And in this, I like to add in, discuss usual risks, side effects, and benefits, including the risk of developing suicidal thinking and including the risk of activation as important ones, and advise family to call should there be any questions at any time.
Great questions, and thank you, Dr. Steinbuchel, for answering them. There's another question about CME credits. We'll hand this over to Jessica and see if you can help with that. But any other questions regarding SSRI and how to use and manage starting and continuation of SSRI or tapering?
I'm just having a chance to glance at the questions that that Dr. Wang answered in the Q&A, and I guess if there's one thing in here around the screeners. I think these screeners are really helpful at kind of quantifying symptoms over time. That said, the questions can be interpreted in different ways. So, in the PHQ-9, for example, do you sleep too much or too little? Or, do you eat too much or too little? And so sometimes I like to just ask about those and what that really means and get some often really helpful, more qualitative information, and also the context, and asking maybe why, because maybe they're not sleeping enough because they're, in a room with 4 siblings, or because they're on their screen and they don't track what time it is. So asking follow-up can be really helpful.
Any other questions? Wow, we have Dr. Steinbuchel here.
I'm seeing Sharif Thatch has your hand raised. I'm not sure if there's a mechanism for being able to call on folks or if it needs to be that it's typed in.
Yeah, the question might need to be typed. I think since this is a webinar, we're not, unfortunately, not able to unmute people. Can the recording to be shared? Yes, this will be shared after 1 week.
Okay.
Right.
If there aren't any more questions, thanks everybody.
Thank you. Thank you everyone for your participation. Thank you, our expert, Dr. Steinbuchel, for bringing us a fantastic talk today. We will see you in the 2 separate webinars next month.